So good afternoon. My name is Frasier Kendrick, and I'm the coordinator of partner engagement with UBA. I would like to welcome you to Compliance 201. This special educational opportunity is presented by our valued strategic alliance, CXC. Over the next 5 weeks, we will provide a deep dive into topics such as mental health parity, broker compensation, the No Surprises Act, DOL audits, legislative updates, and so much more, so many more acronyms. Today's session will be led by Stephen Wynn. He is a product manager and the chief architect of the CXC NQTL solution. He is a subject matter expert in several areas of benefits compliance, including non-discrimination testing, Section 125, ERISA, the ACA, and Mental Health Parity Act compliance. His role at CXC involves client consulting, managing strategic partnerships, and developing compliance solutions for brokers and TPAs. So without further ado, I'm going to turn this over to Stephen, and we thank you for being here.
Okay, well, thank you so much, Frasier, and thanks all of you for joining, and to UBA in general for hosting this. I've been working with UBA for many years. This is my first opportunity to present to y'all, so it's an honor for me personally to be able to do this, and I mean that very sincerely. But let's go ahead and jump into our session. So, topic of the session is going to be the Mental Health Parity and Addiction Equity Act of 2008 and subsequent legislation and guidance. So, to start out with what this is, there's a lengthy legislative history here, which is really only interesting if you're a compliance nerd like myself. Basically, it's the Mental Health Parity Act in 1996 made it to where annual and lifetime limits for mental health benefits couldn't be more stringent than physical health benefits, but the lifetime and annual limits largely went away in the wake of the ACA. But the Mental Health Parity and Addiction Equity Act basically expanded on that concept and applied it to the entire group health plan, and also extended it to not just mental health benefits but substance use disorder. So that is ultimately what we're going to be looking at today are the requirements under that law, some subsequent legislation that is passed that impacts what our obligations are. We're going to go through all of the different aspects of the plan that need to be in parity and talk about the implications and the obligations for both health insurance issuers and TPAs, as well as plan sponsors themselves. So, what is mental health parity broadly? As of this, act from 2008, it basically tells us that within a group health plan, the financial requirements and treatment limitations for mental health and substance use disorder benefits cannot be more stringent than they are on traditional medical surgical benefits. So obviously we talked a minute ago about the lifetime and annual limits was the original requirement under the original act. Well, this applies those same parity requirements to the whole enchilada. So we're looking at financial requirements and treatment limitations really covers the bulk of the operations of the plan. I've included a little enforcement fact sheet here. I apologize for the tardiness of this, 2017, but they actually stopped putting these neat little graphics into the enforcement reports. But I think it demonstrates the concept pretty well that we need to look at several different things in the plan, the quantitative treatment limits, the annual limits, things like that. But the bulk of the enforcement was in our non-quantitative treatment limits, or what we call NQTLs. So that's an acronym that you're going to hear a lot of because it really is the most important part of this from the DOL's perspective. And so we're going to get into exactly what these things mean, the different things they apply to, and then talk about what the implications are. So, looking broadly, what must be in parity? coverage in all classifications, and we'll look at the specific parity classifications under mental health parity, basically the categories that we need to be in, within which we need to be in parity. So we need to make sure that every classification that has those mental health benefits, has medical surgical benefits, has mental health benefits, and substance use as well. So coverage in all of the classifications, financial requirements, and quantitative treatment limits are often kind of bundled together. They're similar, but there are distinctions. And then non-quantitative treatment limits. And really this kind of covers this is the umbrella under which all of the MHPAEA requirements fall. So everything that we look at is going to fall into one of these four kind of overall categories. So when we are looking at the coverage in all classifications, these are what we call our parity classifications. So when we're looking at parity for the entire plan, we're looking at that there is parity within each of these classifications. So your inpatient in-network benefits, inpatient out-of-network benefits, outpatient in-network, outpatient out-of-network, but then emergency care and prescription drugs. So within each of those categories, we need to have parity between our physical health and our mental health benefits. And there's a number of different things we need to look at to ensure that that is the case. So moving forward into what specifically needs to be in parity under the umbrella of financial requirements. These are our deductibles, co-payments, co-insurance, and out-of-pocket maximums are really the broad four. So we can't apply higher deductibles, higher co-payments, et cetera, for our mental health and substance use benefits than our traditional medical surgical benefits. And it's something that if it's out of compliance, it's usually going to be pretty obvious. And a lot of folks have fixed their plans to take care of any issues with this, but it is something that needs to be addressed. And there are specific tests that need to be run to look at these specific financial requirements. So for co-payment specifically, we need to look at whether that co-payment, what benefits it applies to, and then if it applies to mental health or substance use benefits, it has to also apply to substantially all of the medical surgical benefits within the same classification. So there's specific guidelines that need to be met for how those co-payments are assigned to specific benefits. So that's, within financial requirements, these are the broad requirements that these need to be in parity between the two. When we look at quantitative treatment limits or some of the others, this can be any quantitative method used to limit the amount of treatment, the amount of coverage. So this could be a limit on the number of treatments, a limit on the number of visits within a given period, the days of coverage within a given period. So quantitative treatment limits, anything like this that is arbitrarily applied to a mental health benefit is likely going to have problems. Now, the big category of this and the thing that we are primarily looking at are our non-quantitative treatment limits. So this is really, this is a very broad category of items that could include a number of different things. There's not a comprehensive list of NQTLs out there because there's so much flexibility and so much diversity in the way these plans are administered and the procedures that they use. But some of the really broad categories of NQTLs we want to look for are determinations for medical necessity and medical appropriateness. How are those determinations made? Is the same criteria applied to both our physical and our mental health benefits? The prior and ongoing authorization requirements, if those are present for certain mental health substance use benefits, we need to ensure that they are present for physical health benefits based on the same kind of criteria. Concurrent review standards, very similar. Formulary design for prescription drugs. This is, a very important aspect of this. We're looking at the group health plan as a whole. So even if a group has, a carved out pharmacy benefit, we need to look at that formulary design for prescription drugs and see how it is designed and see if it, if there are any NQTLs within the prescription drug side of the plan. Plans with network tiers are something that need to be looked at as well. So even if we have the same, operations between two plans, that they're identical on paper, if we have different network access for different classes of employees, we need to look at that network tier design and make sure that it is not running afoul of MHPAEA. And then the criteria for fail first or step therapy protocols, if those are applied more stringently to mental health benefits, that is going to create a problem. And the most common we see really are exclusions for certain conditions. This one is kind of obvious. A lot of plans have written specific exclusions into their plan, particularly self-funded plans, which may exclude, for example, ABA therapy for autism or Down syndrome. So if that is excluded specifically, it's likely not going to, meet the criteria for mental health parity because there's not a similar, medical surgical benefit that is excluded under the same criteria. So non-quantitative treatment limits is a very broad category, as I mentioned before, and it doesn't just include these items. It can include anything that limits, the treatment of mental health. Really needs to be scrutinized and make sure that it is done in a proportionate way to what is being done on the medical surgical side. So let's look at some overall examples of what non-compliance looks like. We've been performing this comparative analysis for clients for a short time now, and have already run into some specific examples. So these are specific examples we've seen in plans that are in operation today of things that needed to be changed. So, under the umbrella of financial requirements, we've seen that virtual health has become, a big item, especially since the onset of the pandemic. And so a lot of plans introduced virtual health into their plans during that time, but may not have taken the mental health parity into account. So we saw an instance of virtual visits being applied for behavioral health required a $35 copayment, whereas a virtual visit for general health required a $25 copayment. This is kind of an obvious textbook example of a violation of mental health parity. There's a smaller copayment for general health and behavioral health. It's non-compliant on its face. An example of another quantitative treatment limits that doesn't really fall under financial requirements would be, a limited number of annual visits for ABA therapy, which we mentioned previously. So if that limited number of annual visits or treatments is not being applied, to another benefit on the medical surgical side using the same criteria, we're likely going to have an issue. And then an example of a non-quantitative treatment limitation. This is one that we found, specifically within multiple plans. It says that ongoing coverage of this ABA therapy requires an updated treatment plan of every 6 months. And we didn't see that requirement applied to any of the medical surgical benefits within the plan language. So this is an example of one of those NQTLs that's not easily categorized, and it's a good example of why this is such a broad category. The updated treatment plan every 6 months, the only reason to do that obviously is to give them an out to exclude coverage for it based on some criteria that is not specified within the plan language. And so when you put these kind of requirements on specific benefits like this, it's going to run afoul of mental health parity. And even if you can prove on the back end that you're applying this criteria similarly, the language in your document stating this is going to be a big red flag for the DOL. So if they did a service level audit, if they just did a tier 1 investigation, and they noticed that in the plan document, it's something that could trigger a further investigation from that point. Oh, apologies. Okay, so we've kind of been through the high level requirements, exactly what we need to be looking for within each plan. So moving forward in kind of the legislative history, we had the Mental Health Parity Act and Addiction Equity Act in 2008. But with the DOL enforcement really started picking up in 2013 and 2014, according to the folks we know that worked there at the time. And they've been kind of working overtime to investigate plans ever since. And what they found was that there wasn't a very adequate response to their investigations. The comparative analyses that they had performed were generally inadequate. Many were not taking the mental health parity into account when designing their plans and designing their treatment limitations. And so it's kind of contributed to an atmosphere of kind of frustration within the agencies and I think within Congress as well. And so this led up to the Consolidated Appropriations Act of 2021, was a large funding bill, and they inserted language into that bill that required group health plans that are subject to MHPAEA to perform and document a written comparative analysis of their plans. So this is a recent requirement that has been instituted. You not only have to perform a comparative analysis, you have to have it written and documented on all of your NQTLs specifically, and be able to provide that to the DOL or a participant upon request. And so there's this large task that needs to be performed. A comparative analysis needs to be written and documented that will include information from both the plan sponsor level and the health insurance issuer and service provider level. So that leaves us with ultimately who is responsible for this. Well, ultimately, both health insurance issuers and plan sponsors have to comply with this. They're bound by the rules themselves. In practice, the TPAs and providers have been basically passing the buck to the plan sponsors within their ASA language, saying that the plan sponsor is responsible for performing the analysis, and us as the TPA, the provider, will provide information as necessary. So ultimately, there's the responsibility is going to fall on the plan sponsor to perform this task, and they're going to need information from the TPA for that to be possible. And so when we look at who is subject specifically on the issuer side, it's the providers, it's the TPAs, PBMs also, because we need to look at the prescription drug aspect of the plans as well. And then on the plan sponsor side, there are very limited exceptions. These rules apply to both fully insured and self-insured. The implications are a little different between the two, but they ultimately both do need to comply with this. It applies to both ERISA and non-ERISA plans, so it's not specific to one or the other. There are some exceptions written into the law for self-funded non-federal government plans, for retiree health plans, etc. I will warn you though, that a lot of states, and we're not going to get into all of the different state requirements on this presentation, but many states have created what are basically mirror rules that will force a lot of these exempted plans to opt in, essentially. So, at the state level, even though you may look at the federal law and say, my plan seems to be able to, exempt itself from the PIA, there may be state law that requires you to cover certain mental health benefits, or it may create, mirror rules, about around what you need to cover. And so state law could remove that MHPAEA exemption. And many states have done this. Other states are in the process of doing it. And so the exceptions to this are really pretty limited at this point, and pretty much everyone's going to have to comply in some form or fashion. Now, when it comes to fully insured versus self-insured, obviously the implications are a little bit different. Fully insured plans generally are not going to have the same kind of flexibility that a self-funded plan has in terms of what it carves out, what it excludes. And so in the case of a fully insured plan, the service provider really is going to have to provide the bulk of the information to perform that analysis. But on the self-insured side, we need to specifically look at their carve-outs, their exclusions, the items that are specific to them. So yeah, for the overall implications of this, obviously a lot of the items that we discussed earlier in the presentation were things that are at the TPA level. So obviously, a lot of the NQTL information specifically is going to be something that needs to be analyzed or information provided from the service provider. It's not something that plan sponsor has responsibility for. So ultimately, what can the plan sponsor do to comply with this? And so ultimately, the plan sponsor is going to be, our recommendation is that the plan sponsor focus on their carve outs, the policies that apply specifically to their plan, the exclusions that apply specifically to their plan, and to fix those when they present an issue on their face, because many individual carve outs can run afoul of mental health parity. So, it's to perform a detailed comparative analysis that meets the criteria of the DOL. It has to be a collaborative effort between the plan sponsor and the service provider. So, in the absence of that information from the service provider, obviously the plan sponsor can only really manage their carve outs and the issues identified within their plan language. So this kind of brings us to what the process looks like for performing this. Obviously the plan sponsor is going to have to take the initiative and perform this analysis and request information from the TPA or service provider in order that the necessary information in order to do it. And that will be information about policies and procedures surrounding NQTLs. It will also be requesting claims data, specific claims data, to do a comparative analysis to identify issues under the surface, things that are not within the plan language that are happening behind the scenes that are causing higher denial rates for specific mental health benefits, for example. So, there's a lot of information that is required from the TPA. What we have seen within the industry thus far is that the TPA's information that they are providing is somewhat limited. They're kind of taking the stance where they're going to provide as little information as they can. And the result of that over the last few years has been some increased aggravation on the DOL side. So something that should be mentioned here is a recent report from the tri-agencies who are responsible for enforcement of ACADEMIES. That's the Department of Labor, HHS, and Treasury. They released a joint report, which they do every other year, that basically outlined their ACADEMIES enforcement efforts in 2021. Looked at the number of plans they looked at, the number that were non-compliant. But one of the most important findings in that report was that of the 177 plans that the DOL looked at in 2021, not a single one was able to provide a comprehensive comparative analysis on the first try. So all of the initial responses were insufficient. So obviously, some of those plan sponsors probably didn't put the required effort into their analysis and misunderstood the requirements, et cetera. There can be many issues for that, but some obviously did do their due diligence and tried to do this as comprehensively as possible, and it still was not sufficient from the DOL standpoint. So what this is telling us, and putting two and two together from what we've seen from service providers, it looks like the NQTL information on the service provider side is where it is typically lacking. It's where they're not providing quite the level of detail and specificity that the DOL is requiring. So knowing this, we need to focus on what the plan sponsor can reasonably accomplish in this situation. So we need to look at, obviously, focus on all their carve-outs and the things that are specific to them. Take a very deliberate process about requesting information from the TPA, be very careful to document all of that communication with the TPA. And basically, we want to get them to the point where they have analyzed their plan as best they can. They have done a plausibly comprehensive analysis with the information that they were provided. And even if it's not totally sufficient from the DOL standpoint, the plan sponsor can say, okay, we've done all that we can, take it up with the TPA. And that's generally what the DOL is doing. So it's the plan sponsors have kind of a murky set of responsibilities here, and are limited by the information that they can get for the most part. So you want to take as comprehensive approach as possible, do everything that you plausibly can, and then hope that the DOL doesn't see any major issues, and any underlying issues that are missing information, they can kick that up to the provider of the TPA. Okay. So, as far as, moving forward, what to kind of expect on this front, we have, it's only going to become a larger issue for the agencies and for Congress. We've seen evidence of really bipartisan support on all of this. I think a lot of folks have been, kind of waiting around to see what Congress does, and thinking that there might be some changes or some more specificity involved. What we're really seeing right now is there's really a bipartisan consensus on these rules themselves, that mental health parity is something that really crosses party lines, and that everyone is really supportive of. And we're seeing that there's organizations within the industry that are not quite there yet in terms of compliance, which has frustrated some folks. And so we've already had Congress people talking about this specifically, talking about basically adding teeth to this. Right now, ultimately, the biggest risk for a plan sponsor with regards to this is that if the DOL found you non-compliant, they can inform your participants, they can inform the state in which you live, and in extreme cases, they can go after you, legally speaking. So what the biggest risk in that process is that if they found something within the investigation process that was flagrantly violating mental health parity, you could have to re-adjudicate claims dating back to years in the past. So if there could be years of denied claims that would have to be adjudicated. And an important consideration there is that stop loss coverage typically isn't going to cover claims from a previous plan year that are re-adjudicated by the DOL. They have very specific timelines that need to be adhered to for claims to be covered. So re-adjudicating claims by itself can be pretty serious, obviously. But it sounds like Congress is pretty intent on instituting more teeth to this law and putting specific penalties in place. Something similar to an ESRP payment on the ACA side, where there would be specific financial penalties along with that re-adjudication of claims. And we've already seen the DOL start to enforce this monetarily at the issuer level. In March, there was of 2021, there was a settlement for United Healthcare, I believe in the in the 8-figure range, regarding, and that was regarding specific exclusions for ABA therapy and some of the specific things that we've looked at today. So Congress is pretty intent on giving them more teeth and more enforcement capability throughout this this area. And you may have noticed in the State of the Union address most recently that President Biden actually mentioned that specifically, that mental health parity was going to be, parity between mental health and physical health was going to be, a priority of his administration. And the agencies have taken have made it their top priority as well. So it's not something that's going to go away, and could get more and more teeth to it as time comes along. And it's going to be more, all the more important to be proactive about this and get an analysis performed on your plans. So now I know that's a lot of information in a short time. I actually got through the presentation material a lot quicker than I had initially expected. We've been working to make this concise, and so it appears that I've succeeded on that front at least. So I want to get into go ahead and jump into some of the questions that we've seen in the chat. So the first question is, what if behavioral health telemedicine follows a specialist copay, and is that compliant? It depends on a number of factors. So we've seen a lot of telemedicine benefits that are out of compliance with this in terms of charging higher copays specifically for behavioral health than for general health. If behavioral health with regards to telemedicine does need to be treated in parity with the other. And so if you have, a smaller copay for general health, and then, specialist copays where all of the mental health fall under that specialist bucket, that seems like it would be running afoul of mental health parity, because you're not classing out those mental health benefits into specialist and non-specialist. If you consider all of the behavioral health benefits specialist and subject to a higher copay as a result, that is going to be an issue on the mental health parity front that would need to be addressed. So the next question, any special considerations for self-funded groups with tiered arrangements? I believe this is asking about specific network tiers, and this is something that is covered under our NQTL categories. So when we have multiple network tiers, and our parity classifications, distinguish between our in-network and out-of-network. And so when you have separate networks, the structure needs to be looked at. And so it's hard to say, a tiered network wouldn't be out of compliance on its face by its very virtue, but it would depend on how those networks are created. And if one of the networks, for example, doesn't include any mental health professionals, that is something that could run afoul of mental health parity. So it's something that when we perform the analysis on a plan, we want to look at both of the networks and identify the differences between them, and if mental health benefits are being limited by virtue of the network design. So the next question is a fantastic question. Self-funded groups, sometimes only 100 to 200 employees. How would a group that small have the bandwidth or the expertise to perform this comparative analysis? And that is an excellent question. It really is a work-intensive process. It requires a lot of research and critical thinking. It's something that obviously smaller companies aren't going to have the bandwidth to do it, and ultimately it's obviously you can seek out a service provider that will take all of that load off of your plate, or at least you'd be responsible for providing them with information. You would want to vet those vendors very specifically and make sure that they're covering all of the different parity classifications, all of the that they're looking at all of the plans, that they're looking at the prescription drug aspect as well, and that they're going to handle, look into how they're going to handle the TPA portion of it. The information request to the TPA is going to have to be very specific, very detailed. And so, if you ask them to perform an analysis, they're going to send you something very generic that is not quite going to meet the expectations of the DOL. So working with, the most important, a small group can do is work with somebody, an advisor, be it their ERISA counsel or a third-party vendor that will handle the subject matter aspect of it and make sure that you're requesting all of the information that you need, and in an ideal case, actually performing that analysis as well. Yeah, and so the follow-up comment to that was, many employers aren't going to have the budget to hire someone to do that analysis, and so it's a problem for sure within the industry. Larger companies do have the bandwidth, the resources to do this kind of thing, but smaller employers do not. And so some of the really small employers can get around this, a number of different ways. Obviously, there is still, an opt-out possibility depending on the state that you're in, where a plan can opt out of mental health benefits entirely. Now, the DOL does not want to incentivize people to do that, obviously. They'd rather get a plausibly compliant plan in place that offers those mental health benefits. So it's a difficult question with not an easy answer at this point. We're hoping that as more legislation, more guidance comes around, we can have more of a cookie cutter type process, where it's not as in-depth and not as dynamic, some kind of template that we can use. And the simplest way, if someone was going to go about this entirely themselves without any third-party help, is to go find the DOL self-compliance tool. It's easy to find via some Googling. There is a compliance tool that is really just an informational document that takes you through all of the requirements you need to look at. So if someone was going to take on this is a big task, but if someone was going to take it on, that's what I would use as my starting point, was the self-compliance tool from the Department of Labor. The next question is, how often does an analysis need to be done and documented? Another great question. So, it's really not an annual type requirement, such as reporting or testing, some of the other typical compliance tasks that are compliance obligations that we deal with in this space. It's really meant to be an ongoing process. So, ideally, you would perform a comparative analysis, on every aspect of the plan. And then you would want to keep that analysis up to date on an annual basis moving forward. So basically, the things you would want to, we'll take a look at the plan as it exists right now. The plan language, the operations, the claims dating back as far as we can get them. Look at everything as it exists. And then before each plan year, each subsequent plan year, the plan needs to be evaluated for any changes that are made to the plan that would require additional analysis. If you've removed, moved or added exclusions, if the co-payment structure has changed, if you determine that there are any changes in the plan that require updated analysis, that needs to be done. And obviously the subsequent analysis will be less because you've already looked at all of the other aspects of the plan. And the second thing to look for in your annual update process would be any recent guidance from the DOL. Obviously, if legislation comes down that adds new requirements, those need to be dealt with. If there's a new FAQ that comes out from the DOL that maybe gives us more specific examples of non-compliant NQTLs or something of that nature, you want to go through and check for those things within the plan as well. So, it's less of an annual requirement, more of an ongoing requirement. The bulk of the work is going to be that original analysis, the upfront work. And then from that point forward, it's just about keeping it updated from year to year as the plan changes and as we learn more from the agencies. So I believe that's the last question on the list. Please feel free to jump in and add some questions if you have anything. But as far as the core content of the course, that should wrap us up. So Freja, I'll kick it back to you.
Yeah, so does anyone have any other questions? Even something else? We've got some time, obviously. If anything does come to you after this and you'd like to present a follow-up question, just email us at support@ubabenefits.com and we'll make sure that Stephen and his team get it. I'm not seeing any other questions. So it looks like we just gave you a little bit of your day back, and we look forward to seeing you next week with a new presenter for the next 3 weeks, and we'll see you then at 2 o'clock. Thank you, everyone. And yes, we are doing a recording of this, and the slides are available all on the community, and I'll go ahead and send out a reminder message for next week and with the link to the community and the presentation when the video recording is available. Thank you so much.